professionally wise. So hopefully by the end of the hour, I can convince you why it is. The theme of the talk is going to be sort of brought to you by the number 3. So we're going to have 3 objectives, and within each objective, 3 kind of take-home points. But the overall theme is, although it might seem like opposing sides of a spectrum, there's actually, I think, a lot of overlap between palliative and emergency care, and by integrating the two, I think it could really make a positive change for the care of our patients. So this is the first time I have a disclosure. And it's not a big deal, but I thought I should mention that I am developing a course sort of distilling the essentials of palliative care for emergency practitioners, and receiving an honorarium through Palliative Canada. And then before we get into the nitty-gritty, it's Thursday, so we're going to talk a little bit of a throwback Thursday. So 6 years ago now, I was standing here and giving a grand rounds talk on palliative emergency medicine, and I was looking through it the other day, and it's super naive, you know. I think you think you're all like enthusiastic, and I was like, this is how you treat pain and nausea, and although it was a little bit naive, it kind of prompted this interest of mine, and most of you probably know that I ended up doing a fellowship in palliative medicine during my residency. But I also wasn't the only one. And in 2009, ACEP incorporated palliative and hospice medicine as an official fellowship in their training. It's not yet that way in Canada. But over the last 6-7 years, there's been a kind of an explosion of the literature examining this overlap. And now there's probably a handful of people like myself who are dually trained and working in both. And so I think there's a little bit of nidus for change. So that kind of had me a little bit excited. So although, as I said, people sometimes think, you do what? Palliative care and emergency care? Isn't emergency where people enter the healthcare system, and palliative care where they exit? I actually see what I do a little bit more of this as on the same end of that spectrum. And, although there's a lot of fellowship opportunities in emergency medicine and people are doing, resuscitation and trauma and ultrasound, I think palliative care is actually the one thing that applies to all of our patients, and not just in an end-of-life kind of way. When people come to the emergency department, they're suffering, they have a symptom, and, the word to palliate is to make things better, and it's to make people feel better. And I think that, of all the subspecialties of medicine out there, there's probably 2 of them that are symptom-mediated, and it's emergency medicine and palliative medicine. So that's the main overlap that I see when I'm wearing either my emerge hat or my palliative care hat. And if you don't believe me, you can maybe believe Tammy Quest, who's a bit of a pioneer in the States looking at this overlap. And this, to me, rang true, that emergency clinicians probably provide palliative care in their daily practice, and we've done so since the inception of our specialty. Because when people come to us, they're suffering, and they have nowhere else to go, and it's a safety net of the healthcare system. And what palliative care physicians try to do is just relieve that suffering. And so that kind of rang true to me. And if you don't believe that expert, maybe believe choosing wisely, and maybe by a show of hands, people are aware of choosing wisely, the campaign. So it's pretty evidence-based. Different specialties have adopted it and have made sort of top 5 tips as to how we can improve care for our patients. And what the choosing wisely top 5 are these. I don't know if that projects very well, but avoid CT heads and asymptomatic patients, sure. But if you can look at the third one, and in case that's not projecting big enough, it's actually this. So when I saw this, I was super excited. I think this is huge, that of 5 things you could have talked about with toxicology and diagnostic imaging, pediatrics, EMS, they're saying don't delay engaging palliative care services in the emergency department because people are likely to benefit. So I think there is a bit of a change coming, and I think we know that with our patient population and the complexity of patients that we're seeing and their huge symptom burden. And palliative care, I think, has something unique that they could be contributing. So we'll get into a little bit of the evidence as to how incorporating palliative care in the emergency department helps our patients. And then we'll look into some screening tools and ways that we can help integrate palliative care into the ED. So I'm kind of skipping to the punchline, and I'm putting this up first, and then we're going to kind of break it out. But these have all been evidence-based interventions done in the emergency department that shows how it may improve care for our patients. So having palliative care in the emerge will improve quality of life of our patients. It can decrease hospital length of stay. It'll decrease ICU admissions and actually decrease some ED visits and ED bounce backs. When I say it's evidence-based, my disclaimer is that the research side of palliative care is a little bit, I don't want to say in its infancy, but it's a little bit less rigorous than other specialties. Ethically, I think we can all understand it's a little bit hard to do rigorous studies. So I use evidence a little bit loosely, but there are some pretty good studies, and I'm going to start with this one. So this came out in JAMA Oncology back in January by a group in Chicago, and what they did, and it was published, what does it say, in JAMA Oncology. So they did pretty much the first randomized clinical trial looking at palliative care in the emergency department. Unfortunately, although palliative care applies to, I think, diseases across the spectrum, a lot of the research still is focused on oncology patients. But so that's, I think, one of the limitations of this study. And it was a little bit of a small randomized trial. But what they did is they looked at adult patients with advanced cancer who kind of had to be cognitively intact, so they had to not be delirious or too altered. And they were randomized to either receiving palliative care in the emergency department or kind of usual care. What they looked at was the change in quality of life 12 weeks after this randomization. So there was a lot of limitations. It was a convenient sample, relatively small group, and they don't really mention in the control group how many people would have then received palliative care either as an inpatient and outpatient. But they did achieve statistical significance with their primary outcome, which was a change in their quality of life. So the scale they use isn't one I think we're familiar in the emergency department. It's the functional, I have it here, the functional assessment of cancer therapy measures. So, but it is used a lot in the oncology literature and the palliative care literature. And on the second half of the screen, you'll see that there was a significant change. So when you score higher, you're feeling better in their symptoms. And other kind of non-statistically difference were that the patients who got early palliative care actually lived longer than the patients who didn't. And they were less often to be admitted to the hospital or to an ICU. So I know I'm kind of going over this quickly, and I'm happy to discuss this more in details later if people want, but the bottom line is that having early palliative care prior to admission to hospital improves quality of life for patients. This kind of surprised me coming from the Lancet in that someone in this past year did a meta-analysis and a systematic review of the literature looking at emergency department attendance by patients with cancer in the last month of life. So again, limited by oncology patients. But it was a relatively good quality paper in that they followed PRISMA guidelines for their systematic review, and they looked at studies from 30 different countries, and it was almost including about 1 million patients. I think the meta-analysis part was a bit of a stretch because there's a lot of heterogeneity in these studies. But some of their interesting results is that palliative care, patients who received palliative care were less likely than those not receiving palliative care to come to the emergency department in their last month of life. Sometimes people, and it's in the Cancer Care Ontario guidelines, where they view emergency department attendance in the last month of life as a decreased quality of life and as a bit of a failure in the system. I tend to disagree with that. I think that the patients that we see in the emergency department have a high symptom burden, and we can probably appropriately intervene. But most people do want to stay at home for end of life, at least in Canada, and the most recent studies would say about 70% of people, when actually it's the opposite that's true, or 70% of people end up dying in acute care hospital. And so I think the argument from early palliative care is that, us being the gateway of the healthcare system, if less people are actually presenting to the emergency department, then perhaps we can keep people where they want to be at home. If a patient is presenting to the emergency department, this study in supportive cancer care of this past year shows that having early palliative care will probably decrease their length of stay. So this group is, again, out of an oncology center in Texas. And this is one of my favorite studies, and as a plug, if any residents are looking for a research project, I think this would be something pretty easy to replicate in our center, in that they essentially looked at emergency consults, so that's EC on the top, and they matched those numbers with some inpatient palliative care consults, and then they just looked at patient characteristics and differences in outcomes and treatments. And they saw that early palliative care decreased the length of stay by about a day and a half for patients. I mean, is that clinically significant? Like, maybe. I think so, when you think of healthcare costs, and applying that on a great denominator. A day and a half length of stay results in a lot less admissions and burden on the healthcare system. And the last study I'll show that I think kind of illustrates the importance of early palliative care is from this group who, although palliative care was just sort of a snapshot of what they did, they kind of redesigned, maybe other people have heard of this as well, their whole emergency department to tailor better to a geriatric population. And, you know, they screened patients, 65-year-olds and older, with a screening tool, which I'll show, and they looked at 38,000 ED visits over a 2-year period. And this is their screening tool. I don't know if we use it here or something similar, I'm not aware. But, you know, just some sort of questions about their people's functional abilities. Have they been bouncing back and forth to hospital? Do they have any cognitive impairments or visual impairments? And if patients screened positive, they were then either referred to sort of like a GEM nurse or maybe a falls prevention clinic or early palliative care. And their primary outcome at the end of their study was to look at the decrease in ICU admission rates in this patient population, which was 65 years and older. And what they found is that, again, it might look small, that their ICU admission rate declined by about 1.4%, but in American values, that corresponds to about $3.14 million to medical care. So, you know, this study, again, patients had to be kind of cognitively intact. They couldn't be critically ill. They had to participate, you know, in the interventions offered. And so it is limiting sort of that subset of patient populations, which probably even could benefit a little bit more from early palliative care. But I think that palliative care is a significant part of this study. So if we kind of put it all together, I don't think it comes as a surprise that palliative care, that the emergency department, is a common meeting point for patients who are at risk of dying, and that the patients that we see, especially the 65 plus, they have a high symptom burden and high symptom needs. And that really the first hours in the emergency department are when we are making decisions with families and treatments that are putting patients on a certain path. And if I think that as not like the emergency department is sometimes seen as a transitional point to hospital, to ICU, but if we can incorporate some meaningful decisions into that time, it can have a long-lasting and probably positive impact for our patients. This might seem a bit out of place. It's the out-of-hospital cardiac arrest from ACLS. And the analogy that I see with this is that over the past 10, 15 years, a lot of the studies were done kind of on the blue circle, like how can we improve ACLS, like epinephrine versus vasopressin or versus nothing, and huge randomized control trials, which often in the case of epinephrine didn't really show benefit for meaningful survival for patients. But once research sort of started looking earlier on the chain with good defibrillation, early CPR, and we have Dr. Vaillancourt as a prime example of great research that's been done earlier in this chain of survival, it's probably when it's had the most meaningful impact for our patients and in changing outcomes. And so I think, I'm not going to call it the palliative care chain of survival, because that's a bit of an oxymoron, but currently, at least on the research world, and I think where we practice, palliative care is most often introduced when patients are hospitalized. But if we can move that arrow upstream, we can probably be reaching a larger proportion of patients who could benefit from possibly different treatment options. And ideally, even, and I've been participating in research and in educational programs with incorporating palliative care for EMS providers. And there are areas in Canada, in Alberta and in Nova Scotia where EMS is kind of doing symptom management at home and a lot of treat and release and linking directly with palliative care physicians to keep people home. And I think that's having a huge benefit for patients, which is, I think, the most important outcome, but also for the healthcare system. I said this already, where people want to be at home. At least that's what the studies say. Canadians want to stay at home for end-of-life care if possible, and about 70% of us would say that we want to die at home. But it's actually the opposite that's true. 70% of Canadians are dying in hospital. And I don't want to kind of focus too much on this because I think palliative care is a lot more than end-of-life care, but there is a disconnect, and I think palliative care has something to offer to help keep people where they want to be. So we're going to talk about some screening tools for palliative care patients in the emergency department. And I know we just started, but I'm going to get you guys to stand up, please. Yeah, and stretch, and even Brandon has to stand up. No spilling coffees. Okay. So stay standing if you've ever seen a patient in the emerge that you thought could probably benefit from palliative care interventions or approaches. You can sit, I won't be offended. Okay, so stay standing in the last 6 months if you've seen a patient with palliative care needs on clinical shifts. What about the last month? Okay, half the room, okay. Mostly residents, okay. In the last week, have you seen patients who might have palliative care needs? And on your last shift? So a month is where I lost most of you. And if someone kind of feels brave, like what sort of made you think that this patient had unmet palliative care needs? Gary?
Nothing is set up for them.
Mm-hmm.
They come into a emerge with all kinds of needs, pain medication control, and they're basically cut off from the oncology services. Like, oh, whoa, we didn't see this person. They haven't had chemo in 3 months. It's not a problem. And in fact, I think that's where palliative care. I think you shouldn't be able to cut somebody off until you've actually made a referral to palliative care to say we're not doing any more chemo or we're not doing any more radiation.
Mm-hmm.
Instead of just saying, well, go see your family doctor and make all kinds of arrangements. I think that's a big deficiency. And these people come into emerge and they've got a lot of care needs and issues. I can't say enough of how great the palliative team has been in looking at helping out to manage this. But this is something I think should be done before they even come to emerge.
Right.
It should be done before somebody's discharged from the oncology service to say we don't have anything else to offer.
Mm-hmm. So just for people at home, so kind of end-stage oncology patients who are a bit orphaned by the system coming into emerge because they have nowhere else to go, right? And they're complex. Mm-hmm. Does anyone else have any patient, maybe a non-oncology kind of situation that they thought could maybe benefit from a palliative care approach? Kathy? Yeah. Yeah, and I think that's, so what Kathy said is that we often don't even think about palliative care in non-oncology patients. And I think cerebrally we can think that these patients might benefit from a symptom approach, but practically, and at least in our local environment, it's really hard to get patients plugged in with palliative care if they don't have a cancer diagnosis, unfortunately. Saw another hand up. Mm-hmm.
A few patients receiving refractory CHF.
Yeah. Mm-hmm. Yeah, and like class 4 CHF has a higher mortality than stage 4 lung cancer. But these are patients that we don't think about for palliative care. So I'm glad you said that. And I think, the point of that exercise was just to say that I think often it's our gut that's kind of telling us that, oh gosh, like this patient's not doing well. But other than our gut, is there any evidence that can help us decide which types of patients would benefit from a palliative care approach, which I say loosely, and that means different things to different people. And it doesn't mean a palliative care doctor. It means maybe just changing your typical emergency approach. And kind of discussing other treatment options for people. So this is an Ottawa study done by Dr. Van Welraven. It was published in CMAG 2 years ago, 2013. And he looked, so this is the first screening method that we'll look at as to if this could apply to the emerge. And why I think this is interesting is that it was all done via administrative data, so very little kind of manual data collection. And they sort of screened, I don't know exactly how, via OASIS or whatever, but they derived and then validated on a different patient population this Homer index, so a high index mortality that would predict death within 1 year of hospital admission. So this was their screening tool, which is like super complicated. But again, all the information was just kind of populated from electronic medical records. And then at the bottom, they kind of came up with a total Homer score. And if you had a score sort of greater than 30, you had about a 10% risk of death within the year. I'll just go back here 1 second. Maybe you can't see, but on your far right, it has palliative care there, which and it had to be an admitting service, which isn't possible in our center, but that kind of gave you a score of 30, just like off the bat. But then sort of if you were older, if you came to hospital via ambulance, if you're admitted directly to the ICU, things I think that kind of makes sense to us. And what's happening, and not yet in Ottawa, but will be happening, is that they're going to be taking this Homer score, and if an admitted patient screened positive, and I think they're using 30 as their cutoff, an email is going to be sent to the attending physician to kind of prompt, like, have you had advanced care planning conversations with this patient? Can we think about the goals of care? Can you think about getting early palliative care involvement? And that study is being done by Dan Kobeka, which is one of the Department of Medicine and ClinEpi people. It's starting in Hamilton, and it's going to be branching out through Ottawa. You know, it doesn't really apply to us because it's for admitted patients, and I don't think it ever would. But it is, I think, an interesting way to kind of just prompt people changing their kind of current train of thought. This is my favorite screening method, and I think it's pretty easy. And this is adapted from a palliative care service in the States, in Mount Carmel, which I think is in Ohio. Hopefully it's projecting okay, but it's things that I think we just alluded to in discussing. So if the patient is coming from a nursing home, potentially they could benefit from a little bit of an alternative treatment plan and a palliative care approach. If they're actively dying, I think that's obvious, but this is, I think, the one that's kind of like true that we don't think about a lot. If they've had kind of more than 2 admissions within the last 6 months for the same problem, maybe we're kind of getting to a place where this is a bit refractory, and you know, the chances of someone recovering back to our baseline is smaller. Or if they've had advanced disease with frequent infections, and kind of complications, then maybe we should be thinking about other approaches to treating this as opposed to kind of shotgun sepsis, antibiotics, ICU, intubation for pneumonia or something. Along the same lines, and this I call this a landmark paper in palliative care, and it's Dr. John Yu is a palliative care and medicine doctor in Hamilton, and published this in 2014 in CMAJ. I think it's a great paper that I often give to residents, so maybe some of you have read it. But how can we identify patients who are at high risk of dying? And I apply this, I say, on a daily basis when I'm working in an emergency room. If I see, they have the cutoff here as 55, but an elderly patient with multiple kind of chronic conditions, stage 4 cancer, end-stage dementia. For some reason, I find we don't often think about dementia as being a chronic condition or a progressive illness when, it's exactly what it is. But my favorite part of this screening question, of this screening questionnaire, is the surprise question. And if you're kind of having a patient interaction with someone and something kind of chirps on your shoulder that tells you that you wouldn't be surprised if this patient were to die within the next year, maybe it's time to think about introducing goals of care or introducing other options for someone other than just admitting to AMA if they're from a nursing home and having, whatever complications. This question came from the UK, from a group called the Gold Standards Framework, and there's some studies that are showing what are the sensitivity and specificity of it for different patient populations, and it's performing pretty well. It's a difficult thing to study, obviously. It's hard to do retrospectively, but I think, at least I think it rings true that if you're not going to be surprised that this patient's going to have a bad outcome, maybe we should be thinking about doing things differently. Another way, so we talked about an administrative way to screen for patients with unmet symptom needs in the emergency department. We talked about like kind of screening questionnaires that a nurse or physician or social worker can be doing in the emergency department. And the third way that's been reported is a patient self-reporting. I'm not like hugely a fan of this. I think you'll be missing a lot of patients in that they have to be able to answer appropriately these needs, and it's very subjective. How much are you suffering from your pain? How much are you suffering from anxiety or depression? But this study here shows that it was a way to capture patients who have unmet symptom needs in the emergency department. So they call this the SPEED tool, which actually isn't very speedy if you're asking like 27 questions, but screening for palliative end-of-needs care in the ED. How feasible is this? I think it's an interesting, maybe again, resident research project. Like we do other screening tools at triage, and GEM nurses get flagged where, hey, this patient is at risk of falls or whatever, and I think that the danger is, or we might be okay screening for these patients, but then we also have to be able to offer them something, right? And if there's limitations in getting patients seen by palliative care, either from a manpower or resource point of view, or because the patient doesn't have a cancer diagnosis, then we're sort of screening patients with not really being able to offer them anything upstream. So I mean, they're out there. They're not hard things to apply. So it'd be interesting to see what happens over the next few years. And it's catching on. I'd say Canada is about 10 years behind integrating palliative care into the emergency department compared to the United States. And there's multiple centers in the States that are using this in their emergency department. So who knows what's going to happen. So this is a bit of an obscure slide. Has anyone ever seen this before? Is Ed Kwok here? He would have seen it. No? No one? No one? Okay. So what it is, it's a formula for change, and Vera Nath, who's the VP of the hospital, kind of introduced me to this in a meeting we had not too long ago. But how do we get change happening in healthcare? And there has to be a certain amount of dissatisfaction with the status quo. There has to be vision, and there has to be first steps, and we have to believe that it's going to happen. And if all that can overcome the resistance, then possibly we can maybe see some change coming. So it's a bit esoteric, but I think that kind of how this applies to what we just talked about, there probably is a little bit of dissatisfaction out there. I know that I sometimes feel dissatisfied with the care that I can provide for patients who have really high symptom needs. And I don't mean kind of what we do in the emergency department. I think we do excellent care, but it's just kind of offering them other treatment options. And believability, I mean, there's research out there that says that it's like better for hospital costs, for quality of life for patients. Families have less atypical grief long term if they have early palliative care involvement in a family member who's dying. And I think what we need are the first steps. And hopefully with that, it'll overcome the resistance to implementing some change. And that's how we're going to kind of swing into the last half. And hopefully we'll have about 10-15 minutes at the end for discussion. But we're going to talk about 3 different models of how we can integrate palliative care into the emergency department. So in Annals of Emergency Medicine a couple years ago, Tammy Quest, who I showed at the beginning, sort of did a bit of a summary paper that showed 3 different ways that we can, clinical initiatives to improve palliative care in the emergency department. And there's kind of a basic way, an advanced way, and a more specific kind of ED integrated focused way. So as an example for the basic integration model, I think that we're probably a good center for that. So as most of you know, but I'll kind of just summarize, the palliative care team works as a consultative team, so no admitting privileges, so kind of similar to GI or ID. There is a palliative care doctor who's on call 24/7, but really, like practically, palliative care is really only available Monday to Friday, 8 to 5. It's a team, so there's a social worker, nurses, and physicians, and that's for the inpatient side of things. Now, I currently work in the outpatient team through the cancer center, so the patients that I see in my palliative care practice have to have a cancer diagnosis, and they have to be relatively well to come and attend an appointment. So it's a bit earlier on in their disease. But I think it services a specific need for patients, but again, limited only to cancer patients. How this applies to the emergency department is there really is no defined relationship or collaboration, and I think there's probably limited integration of palliative care in the emergency department. Of all the consults that the palliative care team sees, about 3% come from the emergency department. And I'd like to see that increase over time. So maybe a year ago or so, I informally surveyed you guys about, have you ever consulted palliative care in the emergency department? And half of us had said no, which I'm not surprised about. And I think the comments sort of illustrate why. Like, didn't know we could. Assume the admitting service would do it themselves if necessary, which makes sense, right? If palliative care doesn't admit, if we consult multiple people, it kind of ends up being too many cooks in the kitchen before the MRP is establishing the plan. Limited availability, so not available at nights or not around on weekend and evenings. As Dr. Greenberg just said, there were a lot of positive comments saying like they offered time and expertise that I don't have and that they're very tender, loving doctors. That was my favorite quote. But as Dr. Duchesne said, so it's not really easy for patients who don't have malignancies, which I find really frustrating because I find it's actually the patients with end-stage dementia, renal disease, CHF who are really orphaned by the palliative care system. As it is currently. And unfortunately, they were difficult to reach and they actually refused to see the patient, which I know has happened not infrequently in chatting with some of you. Here's a plug, and I'm not going to reveal the punchline, but stay tuned for this research project that that Matt has been working on with Ian Steele and Lisa Melnichuk and myself and Deb Eagles about looking at how we're integrating palliative care in the emergency department for heart failure patients. I think it's a really good study, and it really points to ways that we'll be able to change, hopefully, in the future. But I told Matt I wouldn't talk any more about that. So that's, I think, our local experience, probably what most of us are familiar with. And across Canada, I'm not aware of any other services doing things much differently. A lot of tertiary care hospitals have inpatient palliative care units where palliative care doctors kind of run the show and have admitting privileges, which changes things a little bit, but for the most part, they're just consultative models. So some examples looking south of the border comes from the Mount Carmel Medical Center. So this is in Columbus, Ohio, and I showed you their screening tool that they used. And what they did, which I think is great, is they actually have kind of like the equivalent of a GEM nurse or social worker, but like a palliative emergency medicine nurse. So someone who is uniquely qualified and has experience in both palliative care and emergency medicine, who can really, I think, relate to the emergency medicine culture and interact well with the team. And they do what GEM does. So they'll come and either the physician asks them to come or the patient screens positive and they introduce, palliative care symptom management, maybe offer admission to hospice or arranging transfer, to a more supervised environment other than hospital. And although they haven't published a lot that I've seen, one study that they did, which is a little bit old, showed obviously a decreased time to palliative care consultation, so it's in the emergency department as opposed to as an inpatient, but that 10% of patients were admitted directly from the emergency department to the palliative care unit. And if that happened, it decreased total hospital cost and length of stay and decreased patients being admitted to the ICU. So, their take on this is having like a fast response to the emergency department and kind of really honing in on what the emergency department culture, like how we're used to kind of time constraints, et cetera, is key to partnering with the emergency department. I think this would be like my dream world if we could do something like that in Ottawa, but I know that would take time. Other centers have taken a little bit more of an advanced integrative model, integrating palliative care into the emergency department. So the Mount Sinai, which is a quaternary care center in New York City, and St. Joseph Medical Center in New Jersey, they have like kind of I don't know if they recruit or whatever, they have tons of people who are duly certified as emergency physicians and palliative care physicians. And the emergency department has a priority to admitting patients to the palliative care unit. Their screening tool is very similar to the other ones I showed. But in 2012, this is the group that that sort of developed a geriatric emergency department with a specific focus on how they can adapt in care for geriatric patients. And they also provide a lot of education to the residents and to the staff. And, this, unfortunately, I find it's a bit small, that in 16 months they did 131 consults. That's like 8 per month. But the results, I think, were significant in that, they had increased compliance with patients having goals of care conversations and, a category 3, which would be the equivalent in our hospital, kind of signing that and establishing that in the emergency department. And of patients that were discharged home, more than half of them probably would have been admitted if they hadn't had sort of this palliative care approach in the emerge. And of those ones who went home, half of them could have ended up in the ICU according to their disease and symptom burden severity. So, which model works and how could this be adapted to us? Like, we all know that change happens slowly over time, but I think change has to happen, especially when we're dealing with ED crowding and, what they call it, the silver tsunami of like elderly patients who are living longer with complex symptoms coming to the emergency department. And it'll just sort of take some vision and some people who are willing to help with the change. So I'm going to sort of end shortly, but as I said, we kind of looked through these 3 objectives on ways we can screen for patients and how we could maybe incorporate palliative care in the emergency department. But I think the take-home message is that we're more than like a transitional area, and I think we know that, but we have to convince that to patients and to other consulting or services. And our interaction in the emergency department is key in that it puts someone on a certain path, either ICU or AMA, and it has a longer lasting impact than we might think. So we sort of see a patient who obviously is sick and goes to AMA, and we might kind of walk away and see the next patient, but for that patient, they might never get home again. Or when we're intubating someone and sending them to the ICU, they might never wake up again. And if we can take a little bit more time and think about different treatment options for these patients, I think we'll really make a positive difference in the level of care that we provide. So early palliative care is better, and think about palliative care in your vulnerable, sick patients. And I think we have to find ways to work on building connections with palliative care to develop a better integration. It's not an oxymoron. I think it's just good medicine. So I'm going to stop there, and thank you, everyone, for being here. I mentioned a little bit about what's coming down the pipe, so we're closer than we have been in the past about opening a palliative care unit in the Ottawa Hospital at the general campus. And I think that will have a positive effect on our ability to access palliative care for our patients. This LEAP EM is a course that I'm working with Erin O'Connor, who I think most of you know, in developing learning essential approaches in palliative care for emergency medicine practitioners. And so it's going to be kind of like a Cape Road course where one day, kind of top tips on palliative care. And so stay tuned. That should be kind of up and running within the next year, which I hope to be able to reach out to you guys to see if it's of interest. And if anyone is also interested, I'm in the process of creating a palliative care interest group through CAPE with the support of our president, which is very convenient when he's your coworker. And hopefully that'll be a way to kind of foster connections and build on research and making this a little bit more mainstream. And that's it. So thank you very much for listening, guys. I really appreciate it. And if anyone has any questions or comments,